Okay, the clinical history is a 30-month-old under the age of 5, altered mental status, and seizure. So as I usually do with pediatric cases, and with most MRI, but especially pediatric cases, because of the high incidence of anomalies, I begin with the sagittal T1. And I check to make sure all the radial anatomy is preserved. The cingulum, the corpus callosum, around the corpus callosum, the indusium griseum. There is our cingulum. There's our cingulate sulcus. It terminates in the supramarginal or marginal sulcus. Anterior to it and oblique to it, although not well seen, is the central sulcus of Orlando. We've got cuneus, precuneus, paracentral lobule, all discussed before. And while you're looking, I'm sure you have observed a large mass in the posterior fossa. What makes posterior fossa masses so different is the tight space. So missing in the posterior fossa is often, when you're dealing with masses, whether they be primaries or metastases, more catastrophic and more dangerous than the supratentorial space. We have a large lesion. It shows some of the folia that we attempted to illustrate in the Purkingioma or Lemaitre-Duclos syndrome abnormality, and the corduroy type appearance that one sees in proliferation of Purkinje cells in the cerebellum. But unlike our last case, which had mild mass effect, the mass effect is dramatic. And I hope you're looking at all of the other sequences while I am giving you some pointers and dialogue. A key pointer in this case, where the differential diagnosis lies between two major diagnoses, is the cleft between our mass and the brainstem on the sagittal image. You can see it right up on my screen without having to leave your other projections. That cleft tells you our mass is not arising from the floor of the fourth ventricle, which means it's not likely to be an ependymoma. Now, I am going to move on to the axials, which you have already done, but I'll do quickly so. I've got a T2 and a flare on the right. I will turn my attention to the contrast-enhanced axial T1. And so now I have on the screen axial T1 C+, axial T2 fast spin echo, axial flare. Let's articulate and list the findings. A mass. Where is our mass? Is our mass intraventricular? You might need to return to the sagittal to make that decision. Let's have a look. Maybe not. Maybe it's pressing the ventricle forward, thus contributing to the visibility of the cleavage plane between the mass and the brainstem. If we had to say whether it was more above the fastigium or below the fastigium, that would be a difficult call, but I would choose, even knowing the diagnosis, slightly above the fastigium, which might place it near the superior medullary velum. It enhances wildly. Portions of the mass centrally enhance, but it also has enhancement throughout the leptomeninges, the delicate pia arachnoid invaginations. That's apparent both in the axial and the sagittal. But let's not forget that there is also a dural, thick pachymeninges that is more smooth. Now, when it's lumpy bumpy, we worry about carcinomatous meningitis, sarcoidosis, other. When it's smooth, we worry about intracranial hypotension and or overshunting. So in this example, we have a pachymeningeal abnormality, a leptomeningeal abnormality, and they are both enhancing. Look at how on the axial T2, the pachymeninges and its enhancement are completely concealed and hidden by these extraaxial collections, which further support the diagnosis of intracranial low pressure. Why does this patient have low pressure? Because perhaps they are overshunted on the right. So much of what you learned in earlier vignettes and discussions is applying here. Let's continue on now with our mass. Let's go to the coronal projection. This is a flare. I don't think it has a tremendous amount to add in a case like this other than the position of the shunt. You've learned previously how the shunts are placed, where they're placed, how deep they should go, and where they should reside. And this one is residing near the foramen of Monro in the right lateral ventricle. It's appropriately placed, but the right hemisphere may be overshunted, or there could be a leak elsewhere. So pachymeningeal and leptomeningeal abnormalities, same patient. Multiple areas, though, are a bit thicker. For instance, that's too thick. That's not simple leptomeningitis. That's not simple smooth pachymeningitis. It's too bumpy. It's too mass-like, which means that our lesion has disseminated. Let's go back to the T2 and look at the guts of our mass. In fact, the sagittal, not that helpful in terms of the T2 because it's not a T2. But what do we think of the signal of our mass? Will we say it's high, intermediate, or low? I would say it's intermediate or low. And what does that mean? It means it's very cellular. There's very little interstitial non-solid tissue, or there's very little cytoplasm in each cell. In other words, not a lot of water or proteinaceous fluid. So high nuclear to cytoplasmic ratio. Very helpful. So that takes us completely out of something like, say, the pilocytic astrocytoma and many other astrocytic neoplasms. So now we have a mass that exhibits the Zuckergeist or Zuckerguss sugar icing sign of enhancement. There it is. Looks like you put a little icing on your ice cream cone. A plane of separation from the brainstem, dissemination, solidity, low cytoplasmic to nuclear ratio. Person is under age 5. It has not bled. There's probably only one reasonable differential diagnosis or diagnosis, and that is medulloblastoma, also known as a PNET tumor, a primitive neuroectodermal tumor, and these have been lumped together. So my number one would be posterior fossa mass, most consistent with medulloblastoma for the following reasons: A, B, C, D, E. I'd leave some of the lesser supportive information in the body of the report. Number two, the left lateral ventricle has not been decompressed. The right lateral ventricle is shunted and maybe over-shunted. Number three, pachymeningeal and extraaxial signs of low intracranial pressure. I won't say over-shunted or over-shunting with too much vigor because I don't want to paint baby in a corner. I don't want to paint the clinician in a bad light. Never do that. Leptomeningeal enhancement with at least one mass-like area consistent with dissemination or spread of medulloblastoma. Everything else is going in the body of the report. Let's talk about medulloblastoma. So this is an important one. It's one of the more common posterior fossa neoplasms in children, and it results from inactivation of tumor suppressive genes like many other cancers. It isn't that the gene makes the tumor. It's that the gene that prevents the tumor has failed. This results in overexpression of tumor growth factors like the sonic hedge 20, and the incidence, while still low, less than 1 per 100,000, still makes it one of the more common posterior fossa neoplasms in children. Peak is 5 to 7 years of age, usually under age 5. When you get down around age 1, you might start considering look-alike tumors like the ART tumor, or the atypical rhabdoid teratogenous neoplasm. There's no really major sex predilection. Some say slight male predominance. It likes the vermis. It likes the superior medullary velum. In adults, they tend to be more hemispheric, more solid, more oval, but they still are very packed with a high nuclear to cytoplasmic ratio, so they are not cystic masses. They're typically iso-intense to the cerebellum. Only 5% will you see extremes of heterogeneity within these lesions. They enhance either solidly or with the sugar icing sign, the Zucker goose sign that I showed you previously. Now, one aspect of this case we didn't show, because we said that patients with diffusion restriction can have failure of the sodium-potassium ATPase pump. They can be vacuolized, as in CJD disease. They can have high nuclear to cytoplasmic ratio, like this patient, or they can be extremely viscous, like an abscess, hitting home the same point again and again. Let's go to our diffusion image. This is it. Let's go to our lesion. And surprisingly, it is not very diffusion restricted. Let's go to our ADC map, where we should see low signal. It is not very diffusion restricted. So there are some atypical features to this lesion. It is a proven case of medulloblastoma. On spectroscopy, there's elevated choline, which is a virtually useless sign, except in the scenario where we're trying to follow the response to therapy, especially in astrocytic tumors. On CT, medullos are very dense, almost as dense as meningiomas, and if they're close to the surface, you may misdiagnose one as a meningioma. 80% are close to the midline. The older you get, the further they drift off the midline. 90% have hydrocephalus. These are also considered primitive neuroectodermal tumors. The incidence in certain parts of the world is higher. The Maori population of New Zealand, for you Kiwis that are here, higher incidence. Hawaii, higher incidence. And in the USA, non-Hawaiians, the incidence is 5, somewhere around 5 to 9, whereas the incidence in one study, this is just in a very restricted population of children, it was 12 per 106 in one study. So it was almost double in Maoris in New Zealand than what it was in non-Hawaiians in the United States. Now, spectroscopy-wise, this is a place where spectroscopy may play a primary role. The choline peak, not so much, maybe for follow-up. But a taurine peak may help differentiate a PNET, a medullo, from other neoplasms. So that's a little pearl you may want to jot down. Probably for your registrars, too advanced a question. Peak incidence is age 7. The overwhelming majority occur before age 10. As we stated, they like the superior medullary velum. There are variants, including the desmoplastic variety, which is even darker than the standard variety, and these have a better prognosis. These are diagnosed mostly by the pathologist. They're immunopositive for synaptophysin. There's also a large anaplastic variety. This is 5%. They've got big nuclei and big nucleoli. They have a brisk mitotic rate, usually die in less than a year. I've listed some of the cytogenetics for medulloblastoma. They're going to be on MRI online. They're probably a little more complicated than we want to discuss right now, and we'll set those aside. Here are some of the WHO variants, the World Health Organization, for medulloblastoma. You can see they are now subdivided by genetics. So TP53 mutation, mutant, wild type, and so on, which we'll get into in astrocytomas. There are also histologic subtypes, so that's under the microscope, versus chemistry. And so these are usually combined to give you prognosis and the subtype of medulloblastoma that we have. We've got classic, desmoplastic, medulloblastoma with extensive nodularity, large cell anaplastic, and a few others. With modern therapies, 5-year survival is about 65%. They are stratified into low risk, standard risk, and high risk, and that stratification is based on histology and the type of genetic mutation, which will be discussed subsequently. The low-risk ones are WNT activated and SHH activated with P53 wild type. They'll be explained to you in detail on MRI online, a little bit beyond what we want to discuss today. But most patients that develop medullo before age 5 do not do well. So age is a risk factor. Genetics, we can identify a risk factor. Histology, another risk factor. Skill of the surgeon, another major risk factor. Whether they can get a complete resection or not. Metastatic disease at presentation, a very poor risk factor. And two of the worst histologies are large cell anaplastic, medulloblastoma, and medulloblastoma that's disseminated. We'll stop right there. That's a lot of information on medullo, a heavily packed, heavily cellular, very scant cytoplasmic tumor with intermediate signal intensity, sometimes simulates meninge near the surface in the adult, closer to the midline, likes the superior medullary velum, has a cleft between it and the brainstem, allowing differentiation from ependymoma, which tends to bleed more frequently, go out to the sides more frequently, and is seen in a slightly older age group in children, and certainly in an older age group in adults. I've got my midline cut up. This is a patient with a possible stroke, had a tumor biopsy 10 years ago. Also had seizure surgery with brain tissue resection. The patient is 56 years of age. While we're toggling around, you might notice the erosive changes of the tip of the dens as opposed to a fresh, clean, zigzag fracture with edema. This is more irregular, associated with some pseudotumorous proliferation. There are erosive changes. This is the typical appearance of CPPD of C1-2. But that might be a story for the spine section, so be prepared. Just a little sidelight entertainment while you are skewering this case. You might have noticed the cases are getting more difficult. So I've got 3 axials up. I don't know about you. I've got a flare on the left, T1 in the middle, T2 on the right. And I am noticing an amorphous, ill-defined, somewhat infiltrative, with very scant mass effect, but with definite widening of the peripheral aspect of the cerebral cortex. There's signal alteration. I have yet to spot calcium. I have yet to spot blood, but there is a very subtle blush along the inner aspect of the lesion. There has been a biopsy here, so I don't know if that's resolving blood from the biopsy with methemoglobin staining or if it's actually a little bit of petechial hemorrhage from the tumor itself, and I have no way of knowing that. Let's continue on to the coronal flare. And I think we would all admit that a surgeon has been in there resecting portions of the brain that are now encephalomalacic. I think we would also admit that there are innumerable areas of cortical, subcortical, and subcortical U fiber areas of hyperintensity that are not just sitting there, they are widening the anatomy. They are expanding, although subtly. I think you would all admit there are tracks that suggest several prior biopsies. I think it's time to go to the contrast-enhanced MR. Now, I'm going to put up the diffusion image and see what kind of restriction we have. Hardly any. Maybe, and I say maybe because this could be potentially artifactual, one small nidus in the left posterior frontal area, probably near the precentral sulcus or what's left of it. So not an inordinate amount of diffusion restriction, as we would get with a heavily cell-packed lesion. Let's go to our contrast-enhanced image again. We have multiple nodular areas of enhancement, some linear, some round, and they run from both the suprasylvian region to the centrosylvian region. And this abnormality sits around the temporal lobe. It doesn't quite get into the transverse temporal gyrus of Heschel. Otherwise, we might see a subtype of aphasia. That was not part of the clinical history. And to my knowledge, the patient did not have such. So it looks like the precentral gyrus is heavily involved. Here's the central sulcus, postcentral gyrus less so, and then the back of the brain is spared. And by the way, the central sulcus never touches the sylvian fissure. This is a subcentral sulcus right here. So they're always separated. Okay, so I'm giving you some time to digest. It would have been lovely to have a BSI, SWAN, SWI, or venous bold. We do not. And why would it be nice to have had that? To see the presence of serpiginous branching, calcification that is characteristic of this lesion. It occurs between 90 and 95% of the time. Bleeding occurs between 90 and 95% of the time, and that would be oligodendroglioma. So the differential diagnosis is oligodendroglioma versus astrocytoma. GBM, less likely because it's been 10 years. There's only a few subtypes of GBM that allow you to live 10 years. The mass effect is not as extensive as I would expect in GBM. oligodendroglioma grows along the planes of nerves. So it can go all the way from the top of the brain to the lumbar spine, and the patient can be relatively asymptomatic. And then it can go rogue and start to generate nodular areas of enhancement with increased aggressive behavior, often upgraded, upclassified from WHO grade 2 to WHO grade 3, so-called oligodendroblastoma. Or it can go from oligodendroglioma to an astrocytic neoplasm like GBM. Or we could have been wrong for the last 20 years, and it was never an oligodendroglioma, but it was one of the more less aggressive subtypes of GBM, simply misclassified. And now we have a way of classifying it properly right from the beginning. In this case, we don't know. But as of right now, oligodendroglioma with nodular enhancement, recurrent residual oligodendroglioma. Rule of thumb: biopsy, oligodendroglioma; genetics, oligodendroglioma. Every single abnormality on the flare, in my experience, is oligodendroglioma, whether it enhances or not. The most aggressive parts are the ones that enhance. But the entirety of the white matter signal change is oligo. Now let's talk about oligodidactically. The definition, you should write this down. You will get asked this if you're a registrar. The definition of oligodendroglioma is now IDH mutant with a 1p19q codeletion. That's one of the few genetic questions you're going to have to memorize. Up until now, and still, they're classified as WHO grade 2. Peak incidence, 55. Median survival, 10 years. They calcify 90% of the time. They bleed 90% of the time. Neoplastic oligodendrocytes diffusely infiltrate the white matter and the cortex, and they produce what's called perinuclear halos. The vessels, both under the microscope and sometimes on MRI, on high-resolution MRI, look like chicken wire vessels. The chromosome arms that are involved are 1p and 19q as a deletion. And there's an IDH mutation, as there is with almost all, as there is with almost all brain tumors. Isocitrate dehydrogenase mutation. If there is an IDH mutant 1p19q codeletion, these are WHO grade 3 lesions, when they have increased cellularity, mitotic activity, and a few other pathologic points. The key for you to remember is the 1p19q deletion. So no matter what they call it pathologically on biopsy, if it has this deletion, it is no longer an anaplastic astrocytoma. It is no longer a GBM. It is an oligodendroglioma. The survival of this subtype is 8 years, a little less. Unlike many astrocytic neoplasms of the brain, there is some chemosensitivity to procarbazine, vincristine, and CCNU, and temozolomide. Anaplastic astrocytoma, usually the entire chromosomal arm, especially of the first chromosome, is lost. There's a translocation from 1 to 19. The relevant genes, specific genes within these chromosomes, have not been defined. If you lose both chromosomal arms, and this can be identified by fluorescence in situ, this is an awfully bad prognostic sign. So oligo versus astro. This is going to come up for you all the time, because you all see brain tumors. In the latest WHO classification, molecular biology trumps all pathologic, macroscopic, as well as microscopic histologic evidence. IDH mutant lesions that morphologically resemble diffuse astrocytoma that have a codeletion of 1p and 19q are classified as oligodendroglioma IDH mutant. IDH mutant lesions that morphologically resemble oligodendroglioma. So they look like oligo under the microscope, but they don't have the co-deletion, and they have what's called ATRX mutations. They're classified as diffuse astrocytomas IDH mutant. You might say, why are you telling me all this? I'll never remember it. Well, I'm telling you this because the more time I spend on it, the more you're going to get it. This is a molecular biology diagnosis. You can create a spectrum of differential, favoring one over the other, but the final answer is going to come on molecular imaging. It is not even going to come in the operating room when they take the piece of tissue and they look at the doctor and say it's an oligo. Wrong. They got to go back and do the proper genetic testing. So a whole new ballgame. Pediatric oligo. These are really rare. 1% of pediatric tumors. They tend to be more aggressive. They tend to be more often grade 3 than grade 2. There is a specific oligo 2 marker, which is again related to chromosomes 1 and 19. And that's about as far as I would like to take it. But that's a pretty deep dive into oligodendroglioma. For you registrars, they calcify, they bleed. It's a molecular diagnosis. It's a 119 deletion. They're infiltrative. They have a lipidic growth pattern. If they have new onset of enhancement, that usually means they've gone rogue. They've either dedifferentiated into a blastoma, or they were always another tumor like a non-aggressive or less aggressive GBM that has now decided to finalize its behavior. Oligodendroglioma likes the frontotemporal, centrum, semiovalle, and finally, every area that's abnormal on FLAIR in a true oligo is abnormal. Same patient. The original study was on 4/4/12. The new study, 2/26/16. You might remember from the voluminous amount of information you got that oligos survive around 8 or 10 years, unless they are WHO grade 3 or of other negative prognostic indicators at diagnosis. So they usually go rogue 6, 7, year 8, and then live another year or 2. So we're 4 years down the road. Don't know exactly how long that patient had been suffering from that oligodendroglioma, but now the mass effect is more dramatic. There are cystic cavities, some of which have blood fluid levels. 90% of oligos bleed, and they are innumerable. There is likely calcification present, although CT will do a far superior job at elucidating this. The mass effect has increased. The enhancement does show what we described earlier as the chicken wire pattern of enhancement, kind of very delicate, irregular, serpiginous enhancement throughout the lesion. So we see it. Let's go to the FLAIR, where we said that all areas of signal alteration count, and they have expanded and extended. The sagittal and the coronal are a bit better at elucidating the anatomic position of the lesion, which remains almost predominantly suprasylvian. In fact, it is suprasylvian and spares the temporal lobe. It's in the frontoparietal region, involving predominantly the precentral gyrus. Now it's extended into the postcentral gyrus. It's transgressed the central sulcus of Rolando. Let's look at it sagittally. So it's anterior to the supramarginal gyrus. It's predominantly a deeper lesion. It has some atypicality in that they're usually a little more anterior, usually more frontocentrum. This is more parietofrontal centrum, but that's neither here nor there. So this is a patient whose oligodendroglioma has gone rogue. It has progressed, as opposed to pseudoprogression. So now let's talk a little bit about gliomas. I have a case similar to this that I followed for 10 years. From the first day of diagnosis where he seized, he was a billionaire. He set up his entire scientific laboratory on the floor of his penthouse. And he researched and was involved in the original discovery of the code deletion for oligodendroglioma. We followed him with CT every single year. It was fine until year 9, when his seizures were uncontrollable. And then at about year 9.5, we did a CT, and he ended up with a bilobed 8-centimeter mass within 6 months in the center of the oligo. 1 year later, he was dead. Oligo gone rogue. But he lived the typical 10 years of oligo. 6 to 8 years for the more aggressive variants. So what goes into a report? First, are there comorbid abnormalities? Has the patient had whole brain radiation? These are things you need to know. Has there been systemic control over a period of time? In other words, how long has the patient had the lesion? Have they been operated on? You can use terms that will suggest to the surgeon that there's no clear surgical benefit. Things like the lesion lies in an area of extreme eloquent brain, meaning if you take it out, the patient will be aphasic, or the patient will have no motor function. You can say that the lesion is disseminated. That's your way of saying there's no clear surgical benefit. You can imply that there may be radiation benefit. How might you do that? You favor angiocentric lymphoma. You favor primary lymphoma of the brain. You might favor oat cell carcinoma because you know the patient has oat cell carcinoma, and it responds very avidly to certain chemotherapeutic agents. What else goes into your report? Size. Lesions that are less than 3 centimeters are amenable to stereotactic radiation. Lesions bigger than that, not so much, and not so much for the gamma knife. Locations. Posterior fossa, emergency. You cannot sit for 3 days discussing, debating the etiology of a posterior fossa lesion. Phone call while you're sitting there. We already talked about eloquent brain. Edema. Well, I've already said edema 10 times. Why am I saying it again? Because if there is pronounced edema when you're in the ER at the time of diagnosis, that's a patient that needs steroids that night. Something like dexamethasone, probably IV. If you have a MET, how many of them are there? For a single MET, surgery is better than whole brain radiation. Surgery plus whole brain radiation is probably better than surgery alone. Stereotactic radiosurgery is better than whole brain radiation, but it's not better than surgery alone. This is all on MRI Online, or will be on there. Multiple METs. You really only have one option, whole brain radiation. And if there's a really big lesion that is causing obstruction, you can selectively do stereotactic surgery for that lesion. What happens when you radiate? You get inflammation and change in the blood vessel walls. In fact, they can be so dramatic, they can dilate initially and then obliterate. If they obliterate, you can start popping off cavernomas. Now, in the intermediate phase, you get slight increase in perfusion and early necrosis, and then progressive but early cavitation. And this creates pseudo-expansion of the lesion. The lesion enlarges, and this is known as pseudoprogression. In the late stage, you get complete necrosis, so a big cavity, and then peripheral gliosis with sometimes serpiginous enhancement, very floppy, irregular enhancement around the outside. Let's skip over this slide. And this slide, grading of CNS tumors, which I think is probably within your brain at this moment in time with your training. But let's drill down into features that suggest something is low grade. long history of seizures. This patient's had a long clinical history. Cyst with an enhancing mural nodule. Two classic ones, pilocytic astrocytoma. What's the other one? Hemangioblastoma. But many hemangioblastomas are small, cherry red nodules. On histologic exam, if you see eosinophilic granular bodies, that's a sign of a low-grade tumor. Here are a whole host of primary tumors of the nervous system. I won't go into them, but I have broken down tumors by discrete growth and, by diffuse growth, I apologize. And the classic ones are diffuse astro, World Health Organization, usually grade 3, sometimes grade 2. Diffuse oligo, usually WHO, grade 2, sometimes grade 3. Glioblastoma, WHO, grade 4. But now you know, molecular trumps histology. Discrete, pilocytic astro, they do great. Pleomorphic xanthoastrocytoma, they do very well. SEGA, subependymal, giant cell, astrocytoma at the foramen of Monroe, they do very well. World Health Organization, grade 1, occasionally grade 2. Ependymal tumors, they vary with regard to their grading, but they do have a discrete growth pattern. Wow, look at this slide. This is scary. But this is new stuff. This is why you come to a course. This is how we've begun to break down intracranial tumors. We combine the World Health Organization system grade, the histology, the macroscopic appearance with the genetics and the chromosomal analysis. So you can see, just for purposes of demonstration, we've got the isocitrate dehydrogenase mutant and the wild type, which we'll talk about, as two separate entities within the same basic type of tumor, the diffuse astrocytoma. Not to be confused, by the way, with the anaplastic astrocytoma. These are always grade 3. These are usually grade 2. And then these are also subtyped. Glioblastoma, subtyped into IDH wild type, IDH mutant, and NOS, which we'll discuss at a later date. And then you've got another kind of obtuse outlier entity called the diffuse midline glioma, which has a special mutation, H3K27M mutant. Just a demonstration of how molecular genetics have taken over brain tumor management and treatment. And then back to oligodendroglioma, where the 1p19q codeletion memorized by all registrars who are going to take an exam. And oligo is also subdivided histologically into cytomas and anaplastic oligodendrogliomas or oligoastrocytomas or oligoblastomas. Let's skip over our in-depth discussion of diffuse gliomas and diffuse astrocytomas and diffuse oligodendrogliomas. I think you get the point. And I just want to touch on diffuse astrocytomas for a minute. These are non-pilocytic tumors. So when you hear pilocytic, good. When you hear fibrillary, not so good. When you hear gametocytic, not so good at all. In fact, bad. So the spectrum of diffuse astrocytomas can go all the way from a 2 to a 4. When you hear anaplastic, 3. And when you hear 3, then you've got to subdivide into wild type, mutant, NOS. Get the picture? All right. Let's keep trolling down this list of information, which again you'll find on MRI Online. And I want to get to GBM. And GBM is divided up into wild type, mutant, and NOS. Now, why is this important? Because it determines survival. It also helps determine treatment. So when you see a large, wild, mass effect lesion with blood and necrosis and edema, that patient could still live 6 to 10 years if they have the correct morphology. The correct molecular genetics. The IDH wild type, most common, 90%. The survival with radiation, not so good, 9.9 months. The surgical survival with radiation and chemo, 15 months, not so good. Extensive necrosis. So there is a correlation between the morphologic appearance on MR and the molecular appearance. Even though I said earlier, if the morphologic appearance looks really bad and the molecular appearance looks really good, which wins? The molecular appearance wins, even though it looks really bad. But most of the time, they're concordant. It doesn't look so bad on MRI, and it's good molecularly. Now, this is also counterintuitive. When I hear wild type and I hear mutant, which word sounds bad? Which word sounds worse? Mutant, right? Wild's pretty bad. Unless you're 16 years old, it's pretty good. But mutant, that sounds really bad. That sounds like you're from a foreign planet, right? But IDH mutant does better. So the IDH mutant, the most common type is this one. This is a typo, and I will fix it on MRI Online. This should say mutant, and it's 10% of GBM. So 1 out of 10 are going to be IDH mutant. I'll make sure I have that corrected. So if you're writing, correct it. The survival, 24 months with radiation, 31 months with radiation and chemotherapy. That's the average survival. And I've seen people live 10 years with this disease. Necrosis is limited. Here is the appropriate reference. And then we went into low-grade diffuse or diffuse astrocytomas, which tend to be grade 2. Anaplastic astrocytomas, grade 3. And again, we're going to subdivide each of those into wild type, mutant, NOS. Now, we talked about patients that have a pseudo-progression. You radiate them, they necrose in the middle, they expand, they get edema, they look like they're worse, but they're actually better. What's a pseudo-response? A pseudo-response is when you give a patient a medication that obliterates the vascular supply. An example of that would be Avastin. On MRI Online, I have a whole list of every single anti-vascular agent that are used peripherally and in brain tumors. And what it does is it dramatically shrinks the tumor. A tumor can go from 10 centimeters to half a centimeter in 2 weeks. I know because it happened to my sister with a chondrosarcoma using a different kind of anti-vascular agent. So you're saying, well, that's great. If the tumor's shrinking and it's not enhancing anymore, how do I know that it's a fake response? And here's how you know. You've got other measurements of biological behavior, what we call biomarkers or bioendpoints. First thing is, tumor's not enhancing anymore, but it hasn't shrunk. It's the same size. So the enhancement's gone away. Or let's say the tumor did shrink, and the enhancement's gone away, but the choline peak is rising, and the lactate lipid peak is rising, and the diffusion is worsening, and the ADC map is showing worsened diffusivity. Now think about it for a minute. If you are killing something, there should be more diffusion, more mixing, more liquefaction. But if that is not happening, that means that the tumor is actually progressing. So in that scenario, we are giving the anti-vascular agent, and the tumor stays the same, shrinks somewhat, maybe even shrinks a lot, and there's no vascular supply, and the other biomarkers do not follow. It's a pseudo-response. Is that clear? I'm spending so much time on this because it's critically important to your understanding of the diagnosis, management, and treatment of brain tumors. And you will find all of this on our website. I'll start with my midline cut. The history is known GBM. Interval treatment with Avastin. So this is an agent that affects something called VEGF. For you registrars, VEGF, vascular endothelial growth factor, it's something you have to know. So blockage of VEGF by this drug, which was the first classic drug, there are 10 others. So let's see what's happening. Sagittal midline T1. Let's put up the axials. Let's start out non-contrast. On the left, flare. In the middle, T2. On the right, T1. Admittedly, it doesn't look a lot different than the initial presentation of one of our oligos. It's infiltrative. It has mass effect. An area of methemoglobin staining corresponds to a biopsy tract. There's not a lot of bleeding. It has crossed the midline to the other side. Now, although both glioblastoma and oligodendroglioma, where white matter abnormalities are present on the flare, there's disease, this sign is almost 100% consistent with oligo. It's about 85% consistent with GBM. So unfortunately, whether that enhances or not, that is GBM. Now, they made the diagnosis of GBM by histology, because this case is a little bit older. Let's see when it's from, 2012. Today, that diagnosis would be made by histology and molecular biology. Let's look at the C+. Contrast enhanced MR. There's the pituitary gland enhancing. It has autochthonous blood supply. There's no blood-brain barrier there. But it's a C+ compared to the C-. And you might be stunned by the absence of enhancement, which occurs 50% of all GBMs, because there's no disruption of the blood-brain barrier. If you did a first pass, you'll get a 2, 3, 4, or even 5-to-1 increase in signal intensity for a lesion like this. So you'll have very extensive cerebral blood flow on first pass imaging. But on equilibrium phase imaging, which reflects blood-brain barrier, not so consistent. But it's still an aggressive lesion. Do not have diffusion imaging on this case. What else might we comment on? I've already said no blood. Necrosis, none. Herniation, slight subfalcine herniation. Maybe mild subfalcine herniation. How about uncal herniation? A little bit. Effacement of the cistern, the ambient cistern, effacement around the cerebral peduncle, flattening of the cerebral peduncle, flattening of the ventricle, slight dilatation of the contralateral ventricle. We are experiencing mild uncal herniation. What are the other types of herniation? Tonsillar herniation? No. Upward herniation? No. Anteroposterior herniation? No. Brain herniation through a defect post-surgical, a so-called secondary encephalocele? No. These are all checkpoints that go into your report. So what could this have been? It could have been an anaplastic astrocytoma. It looks a little too aggressive in terms of the overall mass effect for World Health Organization grade 2 diffuse astrocytoma. Anaplastic in the diagnosis. Oligo, no blood really, no calcium really. It's in there, but I would probably pick it second. GBM, first. What about something like a gliosarcoma? Much bigger, much more necrotic. What about gliomatosis cerebri? Multiple segments of the brain, multiple lobes of the brain, expansion of each individual sulcus, but usually not sulcus crossing. it respects the sulci. Not as much mass effect as there is with GBM. Often simulates an infarct because of its peripheral location when diagnosed early. It is a very common mistake. So I would pick GBM first. My differential would say something like this. Diffuse involvement of the left inferior olfactory, orbitofrontal, frontal, and parietal regions, including the precentral and postcentral gyri, with deep extension crossing the midline and extending all the way to the peripheral margin of the right orbital frontal gyrus, most consistent with an aggressive infiltrative neoplasm. Favor in descending order of likelihood, GBM, oligodendroglioma, anaplastic astrocytoma less likely. Number 2, early uncal herniation. Number 3, no tonsillar herniation. Let's return now to our discussion of GBM. Okay, so I'd like to take a moment to talk about glioblastoma, even though we have touched on it so far, but it is 50%, unfortunately, of all astrocytic glial neoplasms. So half the time you've got a GBM. So let's begin with primary glioblastoma. We've already talked about grading them by their appearance, by their radiographic appearance, by their morphologic appearance when you remove them, by the pathologist, by their histology, and by their molecular biology, which trumps them all. But we also have another way to look at glioblastoma, which is primary, and these are patients that have had no prior tumor. They simply present with a GBM. They have something known as EGFR amplification, and they have an abnormality at chromosome 10. Remember the deletion that we discussed in oligo, which is not present in GBM. They have another mutation, which is uncommon, called TP53. But if it's a secondary glioblastoma, in other words, progression of another tumor, let's say an oligoastrocytoma gone rogue, they do have a TP53 mutation, and they have rare EGFR amplification. So those are two different behaving neoplasms. So you can actually say in your report, conclusion, with a known history of a prior neoplasm that is now accelerated, favor secondary glioblastoma with a TP53 mutation and absent EGFR amplification. They will be so impressed, and what you're basically doing is you're telling a smaller hospital that that pathology needs to be sent out. That's what you're saying. You're being a consultant, and the complete opposite would be said with a primary glioblastoma. Now, what about a glioma versus a met? You would think that a malignant killer lesion like a glioma, especially anaplastic astrocytoma and GBM, would have a more consistent enhancement pattern. They don't. We're talking injection, 3 to 5 minute T1, 50% will not enhance, or enhance scantily. But in metastases, the enhancement is 98% of the time. So enhancement of a lesion where you're having trouble deciding between the two for morphologic reasons favors a metastasis. If there's no enhancement, it virtually excludes metastasis. What about perfusion? First pass perfusion is high in both, but it's higher in the higher grades of astrocytic tumor, namely GBM. What about the ADC map of diffusion? It is low in both, but the more solid the lesion, the lower it's going to be. So if you have renal cell carcinoma with signet ring cells and lots of cytoplasm, it is not going to have a low ADC value. You have a medulla, it'll have a high ADC value. If you have a highly cellular GBM without necrosis, it'll have a high ADC value. What about diffusion tensor imaging? If you look at the diffusion tensor of a GBM, it's more abnormal in the periphery. In a metastasis, it's more normal in the periphery. You'll find this in MRI online. What about spectroscopy? Spectroscopy is usually more abnormal away from the necrosis at the periphery of the GBM. So if you're going to take a pixel or a voxel, you take it at the edge of the GBM. If you take it for a MET, you take it in the middle of the metastasis. And METs are more often multiple than GBM. We said previously what happens when you radiate. We talked about pseudo-progression and pseudo-response. And I touched on some of the variants of GBM. There's a small cell variant, there's a giant cell variant, there's a gliosarcoma variant, which has an ominous prognosis, and there is an epithelioid form of glioblastoma with eosinophilic cytoplasm that has some molecular correlates to it. So you can see how complex the evaluation of these brain tumors are. There are histologic variants, there is the morphologic appearance, there is the molecular map, which trumps all, and there is the overall histology and the imaging. That next slide was just a slide to show you that there are 3 new genetic pathways, 3 new molecular pathways that break down GBM even further. I alluded to one of these earlier when I was talking about primary GBM and secondary GBM and the T53 pathway. There are now 3 pathways that you can jump off of to determine prognosis, survival, and treatment for GBM. So it is continuing to evolve. I have personally, nor have many of my colleagues, found PET to be a very helpful predictor of survival, response, or pseudo-response for GBM, with one exception: radiation necrosis. In radiation necrosis, the area should be cold with FDG PET. Okay, same patient follow-up. Original study, 2012. This is a preemptive study, 2011. So this is earlier. Very interesting. So there was actually a study before this. So this is the second study, and then you previously saw the third study. I don't think there's a tremendous amount of teaching value here, other than there is enhancement around the biopsy site. Now, most of that enhancement I would ascribe to reactive tissue around the biopsy site, except for one, that one. That lumpy, bumpy enhancement. That would not be consistent with the enhancement of a biopsy site. The rest of the enhancement is commensurate with what we saw previously. However, let's look at the flare, even though it's low field. And you can see the midline crossing has progressed dramatically. The extension to the left orbitofrontal gyrus has progressed dramatically. And everything you see here that is high signal on flare, with the exception of the periventricular abnormalities, is GBM. Let's go to the next. And before I do, I promised you a quick summary of SPECT. Now we're talking not nuclear medicine SPECT. We're talking MR spectroscopy. So MR spectroscopy was novel, interesting, exciting, and semi-useless. But as time has gone on, and we've gotten smarter, and we've gotten more reasonable, and a little less excited, and more scientific, we have learned where to pick and choose our spots. So we're running for daylight with SPECT. So one area where SPECT can be helpful is looking at the lipid lactate peak. Lipids sit a little lower on the spectroscopy scale. Remember our chart? Lazy, lying crooks, stole my insurance. So the lipid lactate peak together, when combined, sits a little higher. Lactate sits at around 3, 3.2, 3.3 parts per million. So when you see this doublet of lipid elevated, lower down, and lactate elevated higher up, you start to think about cell apoptosis. In other words, cell death. This can occur as a result of growth arrest, inflammatory destruction, tumor destruction. And sometimes you'll actually see a lipid lactate peak in the absence of destruction, but with pure, simple ischemia. The reason you get lipid elevation is the cell membrane of many cells within the brain contain phosphodiesterase and phosphopolyesters and monoesters, and these are released. And in releasing, they create a lipid peak. They will also elevate the choline peak. Those phosphodiesterase are lipids. Saturated lipids, therefore, accumulate from rupture of the membrane, but also lipids live in cytoplasm. So cytoplasmic vesicles that burst, along with cell membrane destruction, creates the lipid peak. Anoxia, ischemia, hypoxia, cell death creates the lactate peak. And I'm sorry I said that the peak for lactate was at 3.2. It's at 1.3 parts per billion, with the lipid peak a little bit lower at 0.9 to 1.3. That's my error. I apologize. And what is in lactate? A CH3 methyl group. That contributes to the 1.33 elevation on the spectroscopy scale. So if you can get that with a malignancy, you can also get it with anything that causes ischemia. So cell death, hypoxemia, a stroke. You can even use that to determine whether somebody is brain dead, along with other aspects of spectroscopy. Now, unfortunately, there are some tumors that are not high grade. Most high grade tumors have this. But there's one particular tumor with a cyst that may also show a doublet, and that is a pilocytic tumor. So that is why I advise you to approach SPECT with caution and with great knowledge. Cystic lesion, nodule, doesn't look aggressive. You do a SPECT, it has a lipid lactate peak, it's still a pilocytic tumor. Alanine, 1.7 parts per million. Usually it's a slight doublet. There's a smaller one further up at 3.93 parts per million. It's produced by transamination of pyruvate in hypoxic tissues. Now you might be saying, well, why aren't you showing me the diagram? Here's why. Because they're going to show you the diagram. And all you have to do is have a little chart underneath that says alanine, pyruvate, choline, MI, etc. You keep that little chart right next to your reading station or next to the scanner. And you will get a printout of every single peak. And you look at the bottom, you say, okay, 1.33, that's lactate. 1.47, that's alanine. So it's very rote and easy. And I will have examples of every one on our site. What produces alanine elevation? Meningioma, due to partial oxidation of glutamine. You can also see it in two other tumors less consistently. Central neurocytoma, which is not so aggressive, and PNET, medulloblastoma, aggressive. Acetate and succinate, found at 1.92 and 2.42. These reflect anaerobic fermentation of pyruvate generated from glycolic carboxylation. You use this for brain abscess. It works. But you should be able to diagnose brain abscess by seeing a smooth pattern of thin enhancement that is thinner on the non-peel surface. NAA at 2.02 parts per million. It's synthesized in the mitochondria from aspartate and N-acetyl-CoA by enzymes, specifically aspartoacyclase. They may elevate in rare tumors, one of which is the central neurocytoma. In hypothalamic hamartomas, they're elevated in the neuronal dominant type over the glial dominant type. The neuronal dominant type looks like pure gray matter. The glial dominant type is slightly brighter than gray matter. NAA drops in any disease that affects brain nerve cells. It is a nerve cell marker, otherwise totally nonspecific. So the specificity is really when it's elevated. NAA goes down in most neurodegenerative diseases like ALZ or Alzheimer's disease. GLX, 2.00 to 2.46. It includes glutamate, glutamine, and GABA peaks. It is seen in peritumoral brain edema. It aids in the differentiation of oligodendroglioma. Higher grades of oligodendroglioma have higher glutamate and glutamine and glutamate peaks. But remember, molecular analysis trumps all. Choline. Choline is all the way to the left. So if we're looking at a chart, 1.3 is down here, 3.2 is up here, and it is a salient component of the Kennedy pathway, which is involved in the genesis of phospholipids in the cell membrane. So cell membranes have phospholipids and fat. Vesicles in the cytoplasm have fat. Any disease that produces membrane injury, choline goes up. MS, tumors, infarction, you name it. It is a non-specific elevation on the spectroscopy scale, but it is useful for following the progression of diseases like MS. Choline is phosphorylated by choline kinase. Taurine. We alluded to taurine as an underrecognized, underutilized, but important spectroscopy peak at 3.25, 3.43 parts per million, just to the left. So if I draw out my spectroscopy scale like this, we said, okay, I've got a lactate lipid peak over here, and I've got a choline peak over here. So this would be 3.2 parts per million. This would be 1.33 parts per million. So taurine. Taurine is going to be just to the left of the choline peak. So let's call that taurine. And taurine actually has two triplet peaks. I'm not going to draw them. This is an inhibitory neurotransmitter that activates GABA A receptors. Some people actually use it as a neuromodulator for certain diseases. People actually take oral taurine as a supplement, and it can be very effective for certain diseases. Unfortunately, it is elevated in medulloblastoma, PNET, microadenoma, and metastatic renal cell carcinoma. Where it's useful, medulloblastoma and PNET, to differentiate it from meningioma when it's peripheral or ependymoma. MI, 3.55 parts per million. So all the way to the left. It's a pretty small peak. It's a quadruplet peak, although you can usually only see one peak because the peaks are so small. It's an osmolyte found in astrocytes. It reflects increased numbers of glial cells. In tumors, it's involved in osmoregulation and volume regulation. It's high in a specific tumor, grade 2 astrocytoma. It's lower in high-grade tumors, so that's counterintuitive. This can be one of the more useful metabolites. So you have an astrocytic tumor with high MI, you're going to favor a grade 2 lesion, even though molecular analysis trumps all. Where else is MI high? MI is high when the brain is not active or busy, as in ALZ, Alzheimer's disease, especially in the posterior cingulum. Put a small voxel of the posterior cingulum, you have entorhinal cortex atrophy, you've got ALZ. Myoinositol decreases with increasing malignancy and remains stable if the tumor does not dedifferentiate, so it's a good method of following the behavior of tumors, along with choline. Glycine, more to the left, 3.55 parts per million. It's significantly high in GBM. So MI, low GBM, glycine, high GBM. Glycine is also seen in other tumors, medullopendymoma, central neurocytoma. Huntington's chorea. Well, we're really not on neurodegenerative disease, but we're on spectroscopy. And what is Huntington's chorea? It is a disorder of metabolism. They accumulate lactate in the occipital lobes. Like with all diseases that affect cell neurons, the NAA goes down, not specific. In Huntington's chorea, the reference, which is creatine, actually goes down. This is one of the few diseases where creatine matters. The severity of creatine drop correlates with the severity and the onset of symptoms in Huntington's chorea. How sad. It correlates with the number of CAG repeats in Huntington's chorea, which means you can predict the age of onset that somebody will get Huntington's chorea by the molecular analysis and the creatine level on an MRI. Because it's a metabolic disorder that we'll discuss later, pyruvate will be found in the CSF. I know that's a lot of information stuffed in your brain. But you can see that spectroscopy, there are certain little nuggets of spectroscopy that have begun to improve the imaging diagnosis of disease states, but especially the management and prognosis of disease states like Huntington's chorea. Easy unknown, blind case, should be a 30-second diagnosis. While you're doing that, I'll point out the pulsation artifact commonly seen between the lateral and sigmoid sinuses. That is not real. You can just gaze up for a moment while you're studying. There is ethmoid sinus disease for those of you that haven't taken your medication today. Just kidding. There is a very confluent area of signal alteration, which I would refer to as otomastoid air cell inflammation. Consider CT for further evaluation or assessment with audiometric testing. And then finally, we come to the lesion at hand, which is perhaps best demonstrated in the coronal projection, and that is an extraaxial mass. Is it intraaxial or extraaxial? Obviously extraaxial. It also demonstrates in the axial projection a little bit of a dural tail. There's our tail. It has a rim or capsular sign due to displacement of vessels, a pseudocapsule of fibrosis, and some dura. The amount of edema should not throw you off that this is a meningioma. Edema around meningioma is particularly common. The fact that it goes to the other side is a little bit unnerving. These tumors are seen more frequently in women and can be estrogen sensitive. They can also occlude. This one doesn't. The superior sagittal sinus. There is downward herniation or downward displacement of the right cerebral hemisphere. Temporal horns are not big, so there is not generalized hydrocephalus. We absolutely should, in this 43-year-old man, what is he doing with all this fluid in his left ear and a little bit of thickening in his right ear? He needs a CT. So do not fall into the trap of what I call grotesque bias. In other words, a grotesque, overwhelming abnormality, you fixate on it, you're focused on it, and you forget to look at everything else. Happens all the time. Meningiomas typically are intermediate, they're packed, they're gray, they're firm, they're solid, they're desmoplastic. Only occasionally will they form cysts, and usually the cysts are small. You can rarely have large cystic meningiomas, and 1% of the time, meningiomas may be associated with an adjacent arachnoid cyst. They enhance for you registrars intensely. The enhancement is early. They're like your mother-in-law or father-in-law. They come early and they stay late. The so-called in-law sign. I know about that because I'm an in-law. All right. Meningiomas form from the arachnoid capsule. It is the most common extraaxial tumor in the adult. There are typical and metaplastic ones. Your job is to stop surgery on the typical ones and prompt surgery on the uncommon atypical ones. The atypical ones can be anaplastic, papillary, mesenchymal, and may have scant elements of melanocytes associated with them, or a melanocytic lesion may simulate a meningioma, which is a rather large problem. There are other primary meningeal neoplasms. One is called the hemangiopericytoma. It arises from the pericyte of the blood vessel. It often has a much more perpendicular growth pattern going through the bone. Anytime you see a lesion that is meningeal going through the bone, that is not desmoplastic, that is not firm-looking, that is not gray-looking, think about hemangiopericytoma. And yes, hemangioblastomas, not associated with von Hippel-Lindau, may also involve the same location, but much less commonly. So these two can simulate one another, but this is about 10 times more common than that. I have never seen a meningeal hemangioblastoma. So these are common, 6 per 100,000. Small ones are found in 1.5% of all autopsies. 3% of functional MRIs in one study, meningiomas were discovered. It is as many as 1/4 to 1/3 of intraspinal tumors, typically middle-aged patients, females greater than males, cranial more than spinal, and they have progesterone receptors in 2/3, therefore they're hormonally sensitive, estrogen receptors less common. So people with large meningiomas should not get progesterone. Who gets progesterone? Women who are trying to slow the aging process, women who have had, for medical reasons, premature hysterectomy, and actually progesterone and estrogen regimens are sometimes used in bodybuilders, but they don't get meningiomas. They also use progesterone for patients with hyperemesis gravidum in pregnancy. They're homogeneous, they're hyperdense, they have a hemispheric shape, they're hyperostotic, and they're hormonally modulated. So the 4 H's. 75% are histologically typical, 75% are radiologically typical. The diagnosis in CT is usually simple. They're hyperdense, they're dural-based, and with contrast, they have a dural tail. Etiologic factors for meningioma include trauma, radiation, viruses, familial, meningioma, ependymoma, and a few other tumors that we'll talk about in NF2. Neurofibromatosis type 1 is not associated with meningioma with any frequency, although rarely they do occur. NF2, multiple schwannomas, meningiomas, and ependymomas, the so-called MIS-ME syndrome. Radiation is an absolute risk factor for meningioma, usually low dose. This was discovered in immigrants to Israel in the 1940s who received radiation to the head for ringworm, and they had a higher incidence of meningioma. So superficial, low-dose radiation will produce meningiomas. These are monoclonal tumors. There is a meningioma gene. It's a tumor suppressor gene like most of the tumor genes in the brain. It is not surprising that meningioma consists of a deletion of the long arm of 22. And what is the genetic abnormality in NF2? Chromosome 22. What is the genetic abnormality of an isolated meningioma? Chromosome 22. How interesting. There are some other molecular correlates of meningioma, maps between myoglobin, the C-cyst gene, the proto-oncogene, and this allows separation of meningioma from NF2 meningioma. So in other words, isolated meningioma, they both share chromosome 22, but there is a subset of molecular abnormalities that allow absolute discrimination of non-NF2 meningioma from NF2 meningioma. Where does this come in handy? 16-year-old presents with a meningioma. 20-year-old. You want to know if that is the first manifestation of NF2. You're going to do this test. I'll skip over the rest of the discussion of genetics for now. Maybe a little too much, and a discussion of the locations of meningioma, which you all should know. Falx being the most common, sphenoid wing, tuberculum, olfactory, and posterior fossa. For you registrars, parasagittal and Falx is number one. The actual deletion is along the long arm of chromosome 22, and in patients with NF2, again, there is a discrete difference between the genetic mapping on chromosome 22 in NF2 versus non-NF2 patients. I think I'll stop right there. Children do get meningiomas, and anytime you see one, you have to exclude NF2, a take-home message. I will leave you with some atypical histologies that you can look at on MRI online, including the cystic variant, the anaplastic variant, and the different histologic types. Let's move on. Okay, this is a patient with neurofibromatosis type 1, a temporal lobe lesion. The patient is 12. Since it's a younger person, I will start out with my sagittal. Look for anomalies. Don't see any. Although I have to admit the callosum is a bit funny looking. I'll have to take that back. In NF1, I like to look for focal areas of astrodysplasia. These are known as foci, focal abnormal signal intensity areas. They usually occur symmetrically around the globus. This patient has a few scattered ones. They have a propensity for the visual pathway. Patient does not have it. But there is a cystic lesion with surrounding signal change on the flare. Let's keep looking, shall we? Please do scroll your own station. Feel free to look up as needed. You can look, but there was no diffusion restriction. Contrast enhancement. None, scant, medium, a lot. I would say none. If you said scant, I wouldn't argue with you. Location, temporal. Zone of transition, intermediate. Blood, none. Fat, none. Mass effect, mild blunting of the right cerebral peduncle. Intraaxial, for sure. Adjacent anomalies, perhaps arachnoid cyst in the Sylvian fissure. and the amount of sulcation is in question overlying the lesion. Let's see if we can do a better job at assessing that. Difficult with the mass effect. So I'd have to say questionable. Multifocality? None. Since the patient has NF1, optic nerves, fine. Lambdoid sutural defects? None. Sphenoid wing dysplasia? I don't think so. Let's take a look at the coronal. Not. There is an abnormality in the corpus callosum. There's a cyst in the midline. Probably is a midline arachnoid cyst as opposed to a simple cavum, because there is mass effect to it, but that's not why we're here. But we do have multiple anomalies in this person with a mass. So what is our differential diagnosis? Well, what do neurofibromatosis patients get intracranially? Well, we already said they get FASI, focal areas of abnormal signal intensity, FASI, typically in the corpus striatum, the basal ganglia, and symmetrically or asymmetrically going back towards the optic radiation. They get optic gliomas, which are really areas of pilocytic dysplasia, or true gliomas, pilocytic neoplasms. They get neurofibromas. Typically, the neurofibromas are in the spine, as opposed to the brain, where you're more likely to see schwannomas and multiple cranial nerves in NF2. We said there is a slight increased incidence of meningioma in NF1. They also get systemic diseases, right? So coarctation of the aorta, aneurysms of the aorta, ribbon ribs, aneurysms of the intercostal vessels. With multiple endocrine adenomatosis, they can get pheochromocytoma. They can get bowing of the tibia. They have a higher incidence of multiple non-ossifying fibromas. They have skin manifestations, axillary freckling, cafe au lait spots resembling the coast of California, pigmentary degeneration of the iris, Lisch nodules, brush field spots. And in the brain, we've probably covered the gamut except for maybe one other lesion. Do they get gliomas? They have a slight increased incidence of gliomas, just like they have a slight increased incidence of astrocytomas. So if the patient didn't have NF1, what would our differential diagnosis be? Is it a mass? Yes. Is it intraaxial? Yes. So we have to favor some type of low-grade primary temporal lobe neoplasm. Now, one of the classic temporal lobe neoplasms is a ganglioglioma. They usually don't occur this young. They're often calcified, about 35% of the time. They may bleed, and they tend not to have this slightly bubbly appearance. And I would say that this lesion points to the center. It almost points to the third ventricle, like, look here. That bubbly appearance, that paucity of enhancement, the presence of multiple other dysplastic abnormalities, the absence of calcium, the absence of blood favors the diagnosis of DNET. Do patients with NF1 have a higher incidence of DNET? They do. One of the characteristics of DNET is it has this arrow-like oval configuration. I'll blow it up for you. This is an important tip-off. Slightly bubbly, pointing towards the cistern, arrow-like with a tail, not an enhancing tail, paucity of edema, paucity of mass effect, consistent with DNET. Pleomorphic xanthoastrocytoma, tend to see some high signal inside. Tend to see a little more enhancement. Let's talk briefly about DNET. This is a case they love to put on registrar's examinations. So DNETs are associated with cortical dysplasia. I had a hard time elucidating it due to the mass effect, but they can be associated with other abnormalities. This patient has an arachnoid cyst and most likely a cyst in the midline. The lesions are bubbly. They're wedge-shaped. Our lesion fits both criteria. They scallop the inner table when they're peripheral. They point to the ventricle. This one does. They're temporal. This one is. They have little mass effect for size. This one does. They have little to no enhancement, usually under age 20. Ganglioglioma, older. Unfortunately, unlike some other lesions we've already described, glucose FDG avid on PET. Don't let that send you down the wrong trail of an anaplastic, infiltrative astrocytoma or GBM. If they have seizures, they're hard to control, so the lesion should be removed, especially if it's in the non-dominant hemisphere. This one is in an area of eloquent brain. It's in the dominant hemisphere if the patient is right-handed. So this would be problematic to resect. They are considered World Health Organization grade 1 lesions. There are complex and simple varieties. Pathologically, they have a multinodular pattern. Again, they do like the temporal lobe, and there is a molecular biomarker, the HU deneural antigen. Again, the imaging findings are summarized. On FLAIR, you may see a little high signal around the lesion. Let's go back to our FLAIR and see if that's present. I believe it was. There's a FLAIR, and there is a little bit of FLAIR signal intensity with a paucity of mass effect. Sometimes you'll see enough cystic change within the DNET so that it may simulate other cystic tumors. This is particularly true in adults. But remember, DNET usually under age 20, so if you see something that looks like a DNET that's a bit bubbly in a 50-year-old, you should start to consider another diagnosis. Seizures are common with DNET. I'll stop right there. I have some questions for you that you can answer on MRI Online. DNET, temporal, more than peripheral, points to the ventricles, non-enhancing, doesn't calcify, no blood, no fat, a little bit of FLAIR signal around it, a little bit bubbly, may produce seizures associated with dysplasias. DNET. This will lead us into new territory. But we're flying blind after 12 o'clock. Going to have a very busy day tomorrow. Come hungry, excited, enthusiastic. Bring your IV so you can infuse enough caffeine to keep you alert, awake, and engaged for the entire day. We're going to go really hard tomorrow, unlike today where we relaxed. Okay, gait disturbance. Age, 65. Sex, male. I'll put up the sagittal, even though if I was working alone, I probably would just to take a quick look at the cerebellum and the pons because of the history of gait disturbance. I'm alone, I'm reading, I'm going to put up all three of my axials right away. I've got a PD on the left, not commonly used anymore, a T1 in the center, a T2 on the right. You can put up whatever you want. While you're scrolling, I'm going to put up my diffusion. I've now substituted my FLAIR at the center. enhancement, really none. You're finishing with a difficult one. While you're looking, trying to assess the finding, I would urge you, for sake of time, to put up Series 9, Image 22. It's going to help you a lot. Put that up next to the flare. My guess is a few of you are struggling with this case. It can't all be giant parafalcine meningiomas. So I've scrolled down to the T2 echoplanar B0 diffusion image, and then I've gone to the actual diffusion image where I'm trying to correlate this linear subcortical area of flare hyperintensity along the arcuate sulcus separating, or the intraparietal sulcus separating the superior parietal lobule from the inferior parietal lobule, which you now know contains the supramarginal angular gyrus. So this is straddling the two. So let's go to our diffusion that matches up. Is there diffusion restriction? You bet there is. I'll give you a few moments to reflect, or genuflect, or pray. You choose. Okay, so what are some considerations? The gait disturbance has been going on for about 9 months. I know this case. He's an older spine surgeon. So it's peripheral, right? It's cortical and subcortical. So what about an infarction? Let's talk about the causes of diffusion restriction. Restriction of the sodium-potassium ATPase pump. What causes that? An infarct. We don't have any flow void abnormalities. How many times have you seen an infarct in one fissure, in one sulcus? That doesn't make a lot of sense. And the flow voids, if you reflect back on the rest of the scan, are totally preserved. And the patient has a poor history for stroke. Gait disturbance for 9 months. There was more to the history, but the history was covered up because of his profession and his subtle diminution in surgical skills. So it was not brought forth. What else causes restriction of the sodium-potassium ATPase pump? Anything that is dramatically metabolic. One classic would be recurrent hypoglycemia from over-medication and from diabetes. That's possible, but you would think it would be a little more global. Okay, let's go to viscosity. Hematoma, that's out. Abscess, that's out. Epidermoid, out. Give me another category. Vacuolization, that's right. So vacuolization, heroin, cut heroin. 65-year-old doctor who's doing spine surgery using cut heroin? Kind of doubt it. Been going on for 9 months. Maybe not. All right, we'll keep that one in there. CJD, right? Creutzfeldt-Jakob disease or prion-mediated disease. Long history, failure of cognitive function, decreased diminution in surgical skills, gait disturbance. Okay, that's staying in there. And there are some other really weird genetic causes of tissue vacuolization that occur in the pediatric population beneath 65. Last category, cell packing. A mass effect, lymphoma, oat cell carcinoma, squamous cell carcinoma, tumors without cytoplasm with lots of nuclei packed together. It's not a mass. That's out. So we're only left with two diagnoses: CJD, prion disease, and heroin abuse, or some type of toxicity. I don't like heroin abuse or some type of toxicity. In fact, this patient had gone to visit his family in Argentina and was eating a lot of meat, as they do in Argentina. We don't know if that's related, but when he came back, that is when the decline began. And the decline was slow and gradual, and the gait disturbance history was somewhat of a mask for everything that was going on by his colleagues to protect him. Unfortunately, passed away about 6 months later. Let's talk about CJD and call it a day. So, an excellent way of picking up on a unique finding, knowing a differential diagnosis that matches that finding, diffusion restriction, and going right down the list. Group 1, Group 2, Group 3, Group 4, and each subgroup in those groups allows you to winnow it down to perhaps one, maybe two, but really a single diagnosis. And we made a few phone calls and we were confident in the diagnosis. A very sad outcome. So CJD most commonly occurs as a sporadic mutation, 85 to 90% of the time. Occasionally there is a familial gene mutation, 10% of the time. Iatrogenically, you can get it from corneal transplants, from non-recombinant HGH, from derived transplants, but reports of CJD from blood transfusions are very, very rare. There is a subtype of CJD called variant CJD or consumptive CJD. It occurs in younger individuals, usually average age 28, whereas the other types occur in an older age group. These patients live for about 14 months, and they have a high incidence of thalamic involvement. So this patient's trip to Argentina was probably just a coincidence. One of the characteristic appearances of CJD is something called florid daisy plaques, but more importantly, the presence of diffusion restriction, either asymmetric or more commonly symmetric, in the sylvian region, in a small area of cortex, in both thalami, or symmetrically anywhere in the brain with no contrast enhancement, none. And it persists and stays static for months on months on months in patients with cognitive decline, insomnia, and poor appetite. That is CJD, or one of its offshoots or subcategories. Another name for this condition is transmissible spongiform encephalopathy, which means microscopically full of holes. It's invariably fatal. Another name for it is familial fatal insomnia when it's familial. It is caused by a proteinaceous, infectious, or mutated particle called a prion. So you can actually, in the non-acquired variety, in other words, in the non-food-related variety, these patients will have a particle that they produce from a mutation. The prion resembles a virus. It has no RNA. It has no DNA. There are patients walking around with non-pathologic prions. Prions are very difficult to kill. They have a long incubation period, and that is why ophthalmologic surgical suites have to be kept totally pristine that are doing corneal transplant. These particles can last for years. And when they're exposed to neural tissue, they can produce disease even if they've been sitting dormant on a table for a long period of time. So we mentioned that corneal transplants and contaminated growth hormone and some other potential causes iatrogenically are included in prion-mediated disease. There have been actually no cases of prion disease from blood transfusion. One other take-home point. The imaging appearance, as we mentioned, non-enhancing, static, often symmetric, diffusion restriction, progressive cognitive decline and dementia, somewhere between 6 months and 2 years, and they often have a little hockey stick sign in the back of the pulvinar if there is bithalamic involvement in classic CJD.